Siamo
Hello. Hello.
Good morning.
Good morning, sir.
Okay. So I think everybody is there. Amrita.
Yes, sir.
Okay, Amrita. Okay. Okay. Why principal has entrusted me to take your presence also to ensure morning. Yeah, okay. Okay. So Sajite. So at the end of the presentation, you have to make some to make ensure your attendance. Okay.
Sir, attendance എങ്ങനെ സ്ക്രീൻഷോട്ട് ആണോ? Because കുറച്ച് യൂട്യൂബിലാണ് കുറച്ച് സൂമിലാണ്.
ഏതെങ്കിലും രീതിയിൽ ഒരു ചാറ്റോ എന്തെങ്കിലും ആയിട്ട് അയച്ചേക്കുക. മതിയാവില്ല, ചാറ്റ് പോലെ അയച്ചു കഴിഞ്ഞാൽ പ്രസൻസ് അറിയാൻ പറ്റത്തില്ലേ?
യൂട്യൂബിലുള്ള ചാറ്റും ഇതിനകത്ത് സ്ക്രീൻഷോട്ട്.
സ്ക്രീൻഷോട്ട് ഏതെങ്കിലും അയച്ചാൽ മതി, സ്ക്രീൻഷോട്ട് അയച്ചാലും മതി. കിട്ടുന്നതാണ്. അല്ല, അവർ ചോദിക്കുന്ന സ്ക്രീൻഷോട്ട് ആണോ അയക്കുന്നത്? അവരെന്താ ചെയ്യേണ്ടത്? ഞാൻ അങ്ങോട്ട് പറഞ്ഞപ്പോഴത്തേക്ക് സംശയം ചോദിച്ചു.
ചാറ്റിൽ ഇങ്ങനെ വരുന്നുണ്ട്, അതുപോലെ തന്നെ ഈ റൂമിലുള്ളവരും ചാറ്റ് കിട്ടാൻ മതി.
ശരി. ഓക്കെ.
Yes, sir.
There's a confusion. It's just over. ഞാൻ പറഞ്ഞതെന്ന് പറഞ്ഞാൽ എനിക്കൊന്ന് ഗൂഗിളിലുള്ളവർക്ക്, എനിക്ക് തോന്നുന്നു യൂട്യൂബിലുള്ളവർക്ക് ആൾറെഡി ചാറ്റിനകത്തുണ്ട്. സൂം മീറ്റിലുള്ളവർ എൻ്റെ ഒരു ചാറ്റ് പോലെ എന്തെങ്കിലും ഇങ്ങോട്ട് അയച്ചാൽ മതി. അപ്പൊ നിങ്ങളുടെ പ്രസൻസ് അറിയാൻ പറ്റും, അത് എടുത്തോളാം.
ഓക്കെ സർ. അതിന് സ്ക്രീൻഷോട്ട് ഒന്നും എടുക്കേണ്ട ആവശ്യമില്ലല്ലോ,
ഇല്ല, ജസ്റ്റ് ചാറ്റ് ചെയ്താൽ മതിയാവും. അപ്പൊ അറിയാം. ക്വസ്റ്റ്യൻ ഒക്കെ തരും. ഐ ആം നോട്ട് ദാറ്റ് മച്ച് പർട്ടിക്കുലർ.
ഓക്കെ സർ.
So I think this is my second class for you. Last week I have taken an introduction to the surgery department. Again, we welcome you to the clinical scenario, and one specialty, an important specialty of your clinical scenario is surgery. Surgeons does procedures with a knife. Naturally, he inflict injury to the patient. So that is one. So even though it's not it's a happy event for anybody to get injured, even if it is a planned one, but unfortunately surgeon has to do some injury to the patient. So surgeons used to injure the society or injure the patient itself, but it has to be done with that most care, with all this. So when you take the history and evolution of surgery, it's parallel with the development of the knowledge of your human anatomy. When you go to the history, we have Vesalius and other things who are identified the different anatomical classes. You have learned the technique and where you how do you dissect it, and where are your organs are being situated, and what are the importance of each on the very anatomical location of the organs and its landmarks there. So that's the first and the most important thing that a surgeon has to learn. That's the most important. And that naturally, the more and more information you are obtaining about the prior position of the body parts, that is anatomy, that will help you in it. Then when you inflict injury to the patient, naturally there will be bleeding. So the early surgeons may not be having knowledge about the current way of attaining hemostasis there. You have a lot of ways you are like ligating the vessels. You may apply glue there, you may apply medication there, you may apply heat, that is a coagulation cautery, or different technologies are now available, ultrasound shear, and so many sophisticated physiological things are there. So physics has help us in attaining hemostasis. There is the second way of development in the surgical world. And third one, naturally, you need to have a calm down, unaware patient for the procedure to be performed in a peaceful way, in an undisturbed way. That is the help of the anesthesia. So the Morton's either anesthesia that has the initial one that has changed the scenario. And finally, when you are inflicting injury to the patient, naturally there's a possibility of infection. So when what all things you are doing, when you are doing a glass sculpture, when you are doing a glass sculpture or an ice sculpture, at the end of the sculpture formation, a beautiful picture, a sculpture, you are pouring some water on it, it will melt away. Similar one, what all good work you will do with all this knowledge you have got may get disturbed by the infection that is. So antisepsis is another important aspect of the survival of the patient and the good results of the surgery there. So today's topic, we are going to have the role of the antisepsis, the sepsis, infection in surgery. So it's a major problem in surgical practice already I have mentioned. So two things, a sepsis where you are preventing the entry itself of the organism or killing the organism already getting in it. So two aspects are there, asepsis and antisepsis are. Asepsis is the precautions you are taking. You are normally, when you are walking around, so many organisms are getting. Now the mask you are wearing to prevent a COVID infection is an aseptic precautions you are taking, a protective mechanism you are taking to prevent the entry of the virus into your body system there. So that is an asepsis there. Whereas when you're washing out your finger, with the alcohol, the sanitization or the soap, you are preventing the killing. You're killing the organism in your touching area there. So that is the two things difference there. So that is asepsis and antisepsis. So both are, initially we don't know anything about these knowledges. And that also the knowledge about these two has a tremendous impact on the surgical practice there. And naturally, the treating an infection is even with all these precautions, still you may get infections in a patient. So treating an infection is also very important. So these are the aspects of a surgical infection. So it's very interesting to know the history of all these processes, how it's developed in the entire world history, in the medical history there. So so certain names are very important in that aspect. The first name, Hippocrates, you know very well, the oath, then the Galen, then come the Ignaz, Semmelweis, Louis Pasteur, Lister, the Alexander Fleming. All these people has contributed tremendously in the development of infection control in the. As you know, Hippocrates is the father of your medicine, and he wrote 5 surgical treatises. That is the one that has been there. This is the treaty there, and in fact, he is well known for his oath, Hippocratic. This is the oath, Hippocratic oath there, and that is keeping your ethical practice. How do you practice in your future, and all things depending on all of you has to take an ethical oath, that is being postulated by and now modified a little bit, and initially been introduced by the Hippocrates. Even before that's in the BC, remind you. Hippocratic authors, and this is the ethics, importance of ethics in the medicine there. And he has used wine and vinegar as antiseptic. That is the early dates. So in BC 400, you have got a knowledge about the use of some antiseptics, even though without knowing the exact microbes and other things at that time, he used, because this is important for the survival of the patient at that time. Without knowing the actual cause, anecdotally he used it, and he, in fact, he has described so many things at that time itself, the treatment of wounds, fracture, dislocation, etc. Then comes the next century, you have the influence of Roman. But mind you, this is in a reverse order. So it is interesting. It is interesting because the Galen is the person who has introduced the concept of creating infection. Creating it, so just like you're putting cow dung in the body or an infected agent into the body to get separate, get putrefied. So Galen believes that to getting a wound to get healing, to encourage the healing of a wound, it needs to get infected, because invariably all the wounds are infecting at that time. So he thought that infection or the wound infection, pus formation, all are natural phenomenon, and pus is the one that is promoting the healing. That was a concept that is called laudable pulse. The pus is in fact a laudable one. So wounds are encouraged to produce pus or separate. That was a concept. That's actually in a reverse order thought, but still it is interesting to know that type. Then comes in 1640, William Petty has identified that there is something that is not been identified at that time, nor do I doubt a most formidable army ever before. Earth is a sort of soldiers who smaller are not visible. So he has not mentioned it as bacteria, virus, or fungus, anything, but he believed that there is a small organism, small things that may be the reason for the killing of the patients there. So there comes the Ignaz Semmelweis, very, very important. His name is very important. I think recently also his name came into the war because now everybody is doing what he practiced or preached in 1846 till date, today, 24th May 2021. That's the most important point what you are doing. That is hand washing. So he is a person who introduced hand washing in clinical practice. So that has revolutionized medical treatment nowadays and at that period also. And what was his observation at that time? He observed that during his period, once we are working in a Hungary, he was a Hungarian surgeon, Hungarian physician. He from the Magyar. Magyar is a place, region where from the Hungary he has, Budapest he has came. And in his hospital, he noticed that the purpural sepsis is a sepsis of the mother, the delivering mother, they will getting infection of the genitalia, the anterior abdominal wall, umbilicus, and the child also getting umbilical sepsis infection. So these sort of infections together are called purpural sepsis. He noticed that the purpural sepsis in a group of patients and the mortality, the morbidity of that patients is almost 1:11. One patient among 11 will die of purpural sepsis in a situation where the surgery is being conducted in a teaching institute, where the medical students, the physicians, and all other teaching faculties are being involved in the process of the delivery there. Whereas a setup where, hello? PPT വേണോ ഇല്ലേ? അവരുടെ സർജറി ഓഫീസിനോട് ചെല്ലാൻ മതി. ഞാൻ അവിടെ അറേഞ്ച് ചെയ്യാം. എനിക്ക് മറ്റിടത്ത് അറിയത്തില്ല. ഞാൻ അവിടെ അറേഞ്ച് ചെയ്യാം. Will you please hold on? I have got an immediate thing to do. Just 1 minute. അക്ഷയ് ഞാൻ വിളിച്ചത് നമ്മുടെ ഈ കൊറോണക്കകത്തുള്ള നമ്മുടെ HDICU ഉണ്ടല്ലോ, നമ്മൾ മേളിൽ 5ാം നിലയുള്ള ICU. അപ്പൊ ആ ICUവിലെ AC എയർ കണ്ടീഷൻ സിസ്റ്റത്തിന് ഇന്നലെ എന്തോ പ്രശ്നം ഉണ്ടായിട്ട് അത് നോക്കാനായിട്ട് ഞാനായിരുന്നു എൻ്റെ എല്ലാം കുറെ നടന്നത്. അപ്പൊ അവർ എന്നെ വിളിച്ചത്. അപ്പൊ അത് നോക്കാനായിട്ട് 2 ടെക്നീഷ്യൻസ് അവിടെ വരുന്നു. അപ്പൊ അവർക്ക് 2 PP കിറ്റ് വേണം. അപ്പൊ 2 PP കിറ്റ് ഒന്ന് സർജറി ഓഫീസിലോട്ട് എത്തിച്ചേക്കുമോ? അവിടെ എത്തിച്ചിട്ട് സുനിലിനെ ഏൽപ്പിച്ചാൽ മതി. അപ്പൊ ഇവർ വരുമ്പോൾ അവരവിടെ വന്ന് വാങ്ങിച്ചോളും. Sorry. Okay, so where we are regarding the Ignaz Semmelweis. Okay, so he, am I with you?
Yes, sir. Yes, sir.
Okay. Sorry for the interruption. So he noticed that the people who are getting treatment or being delivery at that time, cesarean and other things are not common. The vaginal delivery that is being done in that center, where 2 sets of people, where patients who are needs a little higher care may be treated in by the teaching institution, whereas midwives are permitted to do a surgery. Even in our part also, the olden days, midwives used to do delivery and other things. So those patients in the same institute might have been done by the midwives also. So those who are doing getting care by the midwives, the mortality is only 1:29, contrary to the higher mortality where 1:11 is the mortality of a patients dying treated in the teaching institute by the experts, in fact. And one more surprising thing is that if the patient delivered at home or before reaching the hospital, their survival is much more better. So that was a funny thing that he observed that. And an important point, he noticed that during this procedure, one of his colleagues get an injury to the little finger during doing because the surgeons or the clinicians who are doing the clinical work are the one doing the autopsy also at that time. Same day, same way, near to the teaching ward, there is an autopsy room also there. It was the practice at that time. And he injured his finger during an autopsy procedure. Unfortunately, he developed the same type of infection from the patient, and he also died with the same symptoms, same disease process. So he observed that that is the process of transmission of the disease. And he believed that the carrying of the infected material from the autopsy room to the ward might have been the reason for the increase in the mortality and morbidity of the patients being treated. So he introduced a simple measure of rinsing the hand with the chlorine water. So he insisted, he put a board in the front of the ward and insisted all the caretakers asked to do a rinsing of the hand washing, in fact, before entering them. And that simple measure has, in fact, reduced the mortality from the 30% survival to 1.5%, even better than the midwives ratio. So that he published that in the journals at that time. But unfortunately, the authorities has not accepted his idea, at that time. So he was rejected, and he wrote so many letters to the medical institutions, medical centers, like the bodies, medical bodies like IMA, ICMR at that time. At that body is available at that time, the Gynecology Association, and I think he wrote all these letters, even public notice also here. So he becomes a nuisance for the authority. Authority getting frustrated by his acts. So they didn't give any sort of attention to him. So finally, there is a rift between these 2 people, and he loses his temper, and they forced him to a mental asylum. And the tragic thing is that Ignaz Semmelweis died in a mental asylum without having any support from the authority. But his work has later getting importance once the pastor identify the germs and the microbes are being dead. But later, now he is being known there with his named university in Budapest, Hungary, one of the leading universities. Semmelweis University in Budapest is one of the leading institutions there. Now the Louis Pasteur, everybody knows Louis Pasteur, and actually he was the father who introduced the microbes theory there, the germ theory there. He identified several bacteria like Staphylococcus, technique of sterilization that we are practicing, the pasteurization there. And he introduced the vaccine that you are now very much interested. Rabies vaccine, the anthrax vaccine, the cholera vaccine. So all these has revolutionized infection and the cough infection there. And in fact, the antisepsis there are by the modern father of modern surgery, the Joseph Lister is a son of a folic acid as an antiseptic, and he rinsed the antiseptic the surfaces to the instruments to getting a clean surgery there. And actually that was the initial talk, his postulation regarding the cause of organism. This we learn details in your pathology regarding the pathological organism, create an infection to a new person and can be re-isolated. So isolation, reintroduction to a normal person to create the same infection from the second. All this happens, that will give a clear idea about Dox posters. Then was a magic bullet by Alexander Fleming. He identified that the mold Penicillium notarum creating a substance that inhibiting the growth of certain organisms. That's the initial introduction of the antibiotic. What are the definitions? When it comes to the proper topic there, you had a definition inflammatory response of presence of microorganisms. So there's a local pus formation, erythema, and other things. Then once it goes into the systemic circulation, so a bacteria into the area make it is a local pathology and signs of inflammations will make it be there. Then once it goes into the systemic circulation, presence of bacteria in the bloodstream is called bacteremia. And another called septicemia. It's a very common terminology still we are using, but in a scientific body, septicemia has been replaced by other terminology like cells and modes. Then another important point that the presence of a bacteria or the bacteria might have been a reason for the infection and cause of the there will be more response to that infection. The cytotoxic storm nowadays with the COVID infection. When the COVID-19 virus, an RNA virus, enter into the nasopharynx, it may get the immune patient may not get a florid infection because of the loss perpetuation. But when it multiplies and invade with its spikes and the AC receptor there and it producing the infection there, that creating lot of host responses. So that host will create so many factors there. So in fact, the morbidity of the COVID patient is in fact much more due to the host reaction of the cytotoxic storm, and that producing the fibrosis of the lung and other things that we know that. So that concept was identified by William Osler, an American physician, as called the father of American physician William Osler. In his Evolution of Modern Medicine textbook, he brought that because of the host reaction, most of the bad things happens due to the infection. When you define the infections, is it getting bored? No?
No, sir.
No, is it clear? When any doubt, because this is a topic, we're going to be having little more pathologic or more theoretical values also there, and we'll have a clinical scenario also. I'll try to explain. So some theory is important here. That is why, because these theory parts are very important for you, and you will learn it in your pathology classes, microbiology classes, in a much more detailed way. I'm giving only a bird's eye view. Just a terminologies മാത്രമെങ്കിലും ഒന്ന് ഓർത്ത് വെക്കാൻ ശ്രമിക്കുക ഈ പറയുന്നതൊക്കെ തന്നെ മനസ്സിലായില്ലേ at least ഈ ഒരു കൺസെപ്റ്റിനകത്തോട്ട് എത്തപ്പെടുക അതാണ് ആയിട്ടുള്ള കാര്യം okay surgical sites nowadays the infection in a surgical patients may be infection in a normal individual without having any surgical exposure may get an infection there or otherwise called a surgical site infection. Site infection means you have done a surgery. You have done a procedure onto the patient. Naturally, I have said already, procedure means you have inflicted injury to the patient by your knife. So such patients getting infection is called surgical site infection, SSI. So surgical site infection is can be a superficial infection or a deep infection or intra-abdominal or called organ-based infections can be of different sorts there. So these are the definitions of surgical site infections there. So infection in a patient, when a wound or when a normal skin with an abrasion or some other way, when you get an infection in the soft tissue or any organ, that produce some body response. I said the responses that is already we have discussed is the SIRS, called SIRS. SIRS is the systemic inflammatory response syndrome. So it's a response to infection by the body's defense system. That's a SIRS. So SIRS, systemically produced SIRS will go into multi-organ dysfunction syndrome, where different organs getting dysfunction function there. So that's called MODS. So SSI is the infection, where you get an initial way of infection. If you treat properly, that will you can abate it at that point itself without producing much of the systemic symptoms there. But if it is unabated, when it goes further, that it produces some systemic responses, host responses there. So that host response is called SIRS. SIRS is the systemic inflammatory response syndrome. So when the SIRS become much more worsened way, it produces MODS. So one of the organ may get involved, organ dysfunction happening. And if uncontrolled MODS continued, it becomes whether it's a failure, total failure, where the renal shutdown, that the urine is not producing in a patient with a systemic infection. It's a MSOF of renal organ. Patient is not responding by talking, become a brain damage. Patient's heart beats are inadequate and become bradycardia or inadequate pumping in a cardiac patient, cardiac suppression. All are organ dysfunction or organ failure, sequelae of a SIRS modes into MSOF. These are the terminologies there. Am I with you? Is it clear?
Yes.
Hello?
Yes, sir.
Okay. Now, what are the changes that are happening in a SIRS? So already I have mentioned when there is an infection in the area, say you have got a injury to your finger. Naturally, there's a pain and other features there. Then second, if it is getting infected and the infection spreading, it goes in the systemic circulation. There, that is called bacteremia, where the bacteria is in your blood. And naturally, that bacteria producing so many facts, so many distal events there. There will be colonization of the bacteria into your gut, because you may not be taking adequate food. There will be hyperperfusion of the gut. So the gut barrier, the gut has got a GIT, the intestinal gut having an endothelium or the lining epithelium there. So that lining epithelium either being colonized by another bacteria, or the epithelial integrity might have been lost by the hyperperfusion, starvation. So what happens? the internal, the luminal bacteria getting translocated. You have got umpteen numbers of bacteria in your intestinal. Even though you believe that there is no bacteria in your body, commensal organisms are larger in number. So this organism, this bacteria, get translocated into your bloodstream, into the bloodstream of the paracolic or para-intestinal lymphatics and the blood vessels there. From there, it goes to the mesenteric lymph node. There, it gets activated, and there is a conversion of the your macrophage formation. The monocytes and other things are converted to macrophages, and that macrophages will create cytotoxins. So that cytotoxins are the interleukin-1 and interleukin-2 tumor necrosis factors. So these cytokines are being released. These cytokines finally turn into sutures of cells and modes that I have already mentioned. So this is the usual way of production of a cells and modes there. So activation of neutrophils and macrophages, they will produce cytokine like interleukin-1, interleukin-6, or to alpha, tumor necrosis factor alpha. These are the cytokines. Then we chemotaxis. Chemotaxis is a migration of the activated macrophages and neutrophils. And there will be release of the lysosomal enzyme, oxidants, free radical, and vasoactive peptides. So these are all other products other than the cytokines are being released into the system circulation when there's an infection. And activation of complement, coagulation, and fibrinolytic pathway. All this will be taking part. These are the actual events happening in the body during the process of a cells formation there. Then, so that will increase the vascular permeability because of the presence of this vasoactive peptide, free radicals, complement. There will be vascular permeability. There is a increased permeability or the C effect of the endothelium of the vessels happens. So the intravascular component fluid will migrate into the extravascular component. Then there will be microvascular occlusion. Smaller blood vessels get occluded. Luminal occlusions will happen because of the coagulopathy, vasodilatation, capillary. All these are the other features that are happening all together. And finally, that led into modes and multi-system organ failure there. So these are another way of presentation. And these are the actual events happening in a overall way. There is endothelial damage. There is a neutrophil activation, monocyte activation, then oxygen radical cytokines, lipid modulators, complement. All this will get activated. And finally, what happened? There's a microvascular occlusion, vascular instability. So this will effectively present as vasodilatation, shock, a capillary leak. There's an edema formation. There is a decrease in the fluid flow, the permeability, the fever, coagulopathy. All will lead on to sepsis and multi-organ failure. This is the end product that happening in a patients with a severe infection. And this depending upon the integrity of the ability of the bacteria. The bacteria has got a cell wall component, that is a shell and other things. Then extracapsular products like toxins also maybe endotoxins are and exotoxins are available. Depending upon the severity and the virulence of that bacteria, it may produce much. And also the host factor, depending on that, you might have heard about the vaccine innate immunity called acquired immunity, and your body's immunity is called innate immunity. So both are important for a patient or a person, depending upon, and moreover, some genetic susceptibility is also there to prevent an infection there. So these two depend on these factors will decide on why some patients are getting more COVID infection and not having COVID infection. So these three factors are the most important one. The innate immunity is important, genetic susceptibility is important, and also the vaccine-created immunity is also important. And finally, because of this, those susceptible patients will develop will have a lymphokine form, cytokine form, neutrophil aggregation, vascular inflammation. All this will lead on to the sepsis syndrome. So in a nutshell of any infection, so infection can be parasitic infection, virus infection, fungus, or bacteria. Similar reactions can be created by pancreatitis. You have got a similar picture in a patient with a pancreatitis trauma burns. So there will be a surge zone. Because of this surge with this infection, you get a sepsis. You get a sepsis. And if it is unabated, it becomes a severe sepsis. And finally shock. It's called endotox. So these are excessive host response, cellular damage, and organ damage. I already have mentioned that the organ damage maybe the major organ in any patients. The infections are the renal. The rest organs are the one most importantly being affected, and primarily it may be due to the in GIT pathology. GIT is the one that is creating the starting point, endotoxemia. That bacteria may be the reason for the endotoxemia. So infection may have been in your hand, but the pathology starts, the systemic problem starts in the GIT, where the bacteria will get translocated, and that translocated bacteria creating the endotoxins and other productions there. And naturally that will have a distal organ area problem. And that organ problem of the permeability coagulopathy all will lead on to decrease in the perfusion in the kidney, may produce renal damage with the urine output. Because so urine output assessment is a very important point. In the lung, you may get microcoagulopathies and microthrombus formation. Just like in the COVID patients, we got a coagulopathy, here also it may happen. So lot of your alveolar get collapsed or non-perfusion. So the ventilation will be ineffective. Ventilation perfusion ratio will be mismatched. So the lung dysfunction may happen. You may have to have larger oxygen supply, or assisted ventilation has to be needed. Similarly, a cardiac infusion might have been there. There's a bradycardia, cardiac output decrease, and finally, sometimes they may get a cardiac shock also there. And in brain also, there may be hyperperfusion. So all organs might have been involved. So depending upon the importance or the susceptibility to that organ, depending upon the infection there, different organs are. And finally, multi-organ. So if you got one organ damage, you can replace. But if more than two or another organs are damaged in a patient, the death is eliminated. So all these are theoretical aspects. So in a clinical aspect, in a patient with an infection, how do you quantify all these things? So how do you define when you suspect SARS in a patient? So when you're seeing a patient with an infection in a hand, where there is a features of infection that you will discuss there in the clinical clinic. So when you suspect SARS, the SARS is a systemic response. So it will produce increase in the temperature. Temperature become more than 38 degrees centigrade or less than 36 degrees centigrade. Heart rate become 90. Heart rate become 90, more than 90, or less than 20. So extremes of the ratio are important. And respiratory rate may more than 20 beats per minute, or the PaCO2. PaCO2 is the mean carbon dioxide saturation, also less than 32. So that also may be an important point. And WBC count may be more than 12,000 or less than 4,000. So these are the criteria to diagnose. So any of the systemic response manifestation by two or more of these features, either temperature and heart rate may be in the same phenomena, or respiratory rate and WBC, or respiratory rate and temperature, any of the two factors, if it's more than that, you have to suspect a SARS. And if there's a SARS with a documented infection, when you have got a patient with a, because fever might have been due to hyperthyroidism also, heart rate increase may be hyperthyroidism, but there is no evidence of it. So that is not a sepsis with the SARS. The same feature you may get a hyperthyroid patient, as a patient with a liver failure. It's similar. So a patient with the features of SARS with a documented sepsis is a SARS. Sepsis, it's a sepsis. So sepsis is defined as SARS plus a documented infection. Infection in the hand, infection in the abdomen, appendicitis, cholecystitis, a liver abscess, anywhere there is an infected source, and features of SARS is a sepsis. If the sepsis creating furthermore events with a organ failure, one or more organ is failed, is a severe sepsis. And finally, it going into septic shock, where inadequate perfusion happens with your adequate fluid resuscitation. Even though you have perfused adequate fluid, but unfortunately his or her BP is not picking up, or his perfusion of the organ is inadequate, meaning that she is in shock, or he is in shock. So that is called septic shock. A sepsis or severe sepsis with a hypovolemia, hypertension is called a septic shock. So these are the definitions of the clinical definition. It is the way you will put it in the clinical scenario, the theory in the clinical scenario there. Can the surgeon predict the chance of infection? What are the ways before seeing a patient, especially important in a surgical patient? You are doing a planned procedure to a patient, an elective procedure. So what are the set of patients who are increased risk of developing infections? So it depends upon the wound factor, depending upon the patient factor, and depending upon the local factors. Wound factors, so the major contamination of the organism in a wound you are inflicting are from patient's own body or from the patient's own wound. It's not, you may believe that, you may think that it may be from the reason why you need to have a clean operation. In fact, it is okay, but only 5% of the infection is due to that. Most of the infections are either from patient's own body, somewhere else, or from the wound itself. So the wounds can be categorized into 4, depending upon the cleanliness of the wound. So if the wound is a clean one, clean means no way of contamination. It's called a clean wound. Sometimes little bit of sterile techniques or some kind of spillage is called a contaminated, clean contaminated. Whereas actual spillage happens, actual spillage of the GIT content when you are doing an appendectomy, pus pouring in that area, or drainage of the abscess there with a pus pouring, or where there is a breach in the integrity of the area, like when you are doing a laparotomy, when you are opening the small bowel, there's some sort of small bowel content might have been spillage to that area. Colonic content must spillage. So that's a contaminated wound. Whereas dirty is already infected area, already infected pus or fecal matter. Here surgery with a sterile area with a mesh, there is a clean case. As a mesenteric, it's a diverticulum, a diverticulitis, infected. So it's a clean contaminator or contaminated case. And this is a dirty one, where you might have seen a lot of eggs are there with the pus is pouring and the fecal. So clean, contaminated, and dirty. So this is the way the wounds are being. So yeah, predictably, you said that these patients, the first patient getting an infection is very less. Chance of infection is very less. Whereas this patient very, very likely to get, even if what all precautions you will take, what all precautions there is a minimal chance of infection there. So you have to take extra precautions during the procedure to avoid florid infection in this patient. You have to have a cleaning of that area, your precautions of antibiotic prophylaxis, antibiotic post-operative way, all are being taken in an extra cautious way in a patients with a dirty or contaminated wounds. The host factor, the patient factor. If the patient already is malnutritious, already having diabetes, renal dysfunction, liver dysfunction, jaundice, having a harboring malignancy, habit of smoking. Smoking definitely increases susceptibility for pathologies like infection. Already on immunosuppressive medications or immunosuppressive treatment like HIV, or steroid, as you know, the steroid, all will increase the chance of infection. And the factors that helping the healing, like the vascularity. If the patient's vascularity is inadequate, as in this patient with a gangrene, naturally there is a chance of infection there because the dead tissue is there. And your surgical techniques, if you left over a lot of devitalized tissue, dead space, hematoma, foreign material with infection, chance of infection. So these are the local factors there. So this is the flow chart of the factors involved, as already mentioned, GT factors, duration, catheterization, chance of wound pressing, all are also important for, apart from the above one, these are other factors that may be influenced by the wound infection. What are the signs of infection? So when you will learn in your pathology the primary acute inflammation. 5 pillars where it will be the inflammatory process being supported is the heat, the calor, the rubor is the redness, the dollar is a swelling there, the tumor is a swelling there, and the dollar is a pain, and loss of function, functionality is a loss of function. So these are the five pillars at which your acute inflammation sustained. So these are the features of acute inflammation. So any injury with infection starting with inflammation, acute inflammation. So the signs of acute inflammations are the calor, rubor, tumor, dolor, and function. So you get a red area, you get a heating temperature or a raised temperature. The swelling, the edema will produce swelling, and the patient will have excruciating pain. And because of the pain and all these features, the functional loss of that area also may happen. So these are the features. So any patient with infection, these features will be there. Apart from there, when there's a surge happening, there's a systemization of the problem occur, you get a fever, you get ileus, and the features of the organ failure. Already I have mentioned about organ failure, decreased urinary output, respiratory rate, heart rate, blood temperature, all other features also will go dominant. And these are the classification of a wound, normal wound. Just take it out. You have the 5 classifications: normal healing with a mild bruise with the evidence of inflammation, edema with the more inflammation, edema, swelling. Then discharge might have been there, or infection. So just take it out in the next week. Different scenarios of presentation there. So already I have mentioned about the surgical site infection. Surgical site infection is the infection in a surgical wound. It can be superficial surgical site infection, or a deep surgical site infection, or an organ space. This is a classification of a surgical site infection, where you get an infection of the skin and subcutaneous fascia in the superficial way, or deeper planes of deeper facial planes, muscle, all on the abdominal wall or the muscle, thigh, or the deep surgical site. Organ space means it is intra-abdominal, liver, kidney, or intraperitoneal, intrathoracic, intracardiac, intracranial. All are the organ space of infections. So different type of these are the post-operative infections. In fact, the previous word of a surgical site infection is post-operative infections. Nowadays, this is better being termed as surgical site infections. Then other infections you may get is the cellulitis, lymphangitis, cellulitis. Here is an inflammation of the subcutaneous and facial planes. You get a skin infection following a trauma, invasion, a skin wound. There's a skin wound there. It can be due to snake bite, bee bite, or scorpion bite. There is a evidence of inflammation. You can see the edematous. You can see the edematous limb. Edematous limb with redness around the wound. There will be pure localization of the edema. Any part of the body may die. So any part that is getting injury is very prone to develop cellulitis, but more common in the lower limb, upper limb, face, scrotum, etc. In addition, the cardinal signs of inflammation, that is a calor, rubor, dolor, functional loss of function, producing further perpetuation of the area and tissue destruction, ulceration, abscess formation, gangrene, necrotizing fascia, and bacteremia. These are the propagation of the cellulitis that may happen. Any doubt? Oh. Any problem? Any disturbance?
No, sir.
Am I clear? Maybe to you?
Yes, sir.
മനസ്സിലാകുന്നുണ്ടല്ലോ, ക്ലിയർ ആവുന്നുണ്ടല്ലോ? എന്തെങ്കിലും കൺഫ്യൂഷൻ ഉണ്ടോ? ബോറടിക്കുന്നുണ്ടോ? ചെറുതായിട്ട് അല്ലേ? ചെറുതായിട്ട് ബോറടിക്കുന്നുണ്ടോ? ഹലോ ഹലോ കുഴപ്പമില്ല, പോവാം അല്ലേ? സോ സെല്ലുലൈറ്റിസ് ആണ് ഏറ്റവും കോമൺ ആയിട്ടുള്ള ഒരു സർജിക്കൽ ഇൻഫെക്ഷൻ യു മേ ഗെറ്റ് ഇൻ. നമ്മുടെ നാട്ടിൽ നിങ്ങൾ ഇത് ആൾറെഡി തന്നെ നിങ്ങൾ പലരെയും ചികിത്സിച്ചിട്ടുണ്ടായിരിക്കാം. നിങ്ങൾ നോട്ട് ആസ് എ ക്ലിനീഷ്യൻ ആര് ചോദിച്ചു കഴിഞ്ഞാലും there's an aberration, there's a wound, there's a lacerated wound or incisor wound that is getting infected and getting an infection. That is a cellulitis. So cellulitis is a skin and subcutaneous fascia, deeper ആയിട്ടുള്ള ഏരിയകളിലോട്ടുള്ള ഒരു ഇൻഫെക്ഷനെയാണ് cellulitis എന്ന് പറയുന്നത്. Features of inflammation will be there. In addition, if it is not being controlled in adequate way because of the organism, with the nature of the organism, it producing features of tissue destruction. It may produce a local destruction of the tissue. Sometimes it may finally, because of loss of tissue or loss of epithelium, that it may get an ulceration. Sometimes it producing abscess formation, and because of the devitalization and ischemia of that area, it may get gangrene, or it perpetuates in a much more worse, much more dangerous situation called a necrotizing fasciitis or bacteremia. This is the way cellulitis may perpetuate. And the organism commonly involved in this situation is a streptococcus. Streptococcus is a gram-positive organism. Another one is a staphylococcus. You will learn in a detail in your microbiology these all organisms. Or gram-negative E. coli, Klebsiella, Pseudomonas. Okay. These are the one usually being involved. I'm not saying that any other Clostridia may make there. Any organism can cellulitis, but these are the common one that is you make it. And when you're a patient with you, you have got all these features of inflammation. Naturally, when you do a blood count, there will be a rise in the total count, leukocytosis. Most often, it is a neutrophil predominating. This bacterial infection will produce a neutrophil predominance, whereas viral may have a lymphocyte predominance there. So leukocytosis with the neutrophil predominance is the one blood count you may get. And most of this patient may be diabetic or immunosuppressed one already you have mentioned. So the diabetic status getting worsened by the infection. Unless it's controlled, the diabetic status, because all these inflammatory processes have got anti-insulin effect. They all are glycogenic. So there is a glycemic increase. It will be how the glycemic level will increase in all these patients with the stress. So the diabetes may become worsened. As I already mentioned, the renal function already lost, more of renal dysfunction, liver dysfunction, and you in a limb patient. In a limb patients, you may suspect a deep vein thrombosis also. Mute you. Okay. So one of the differential diagnosis in a cellulitis and edematous limb. In a edematous limb patient is the deep vein thrombosis. Deep vein thrombosis is the thrombus formation in a vein, like a popliteal vein, femoral vein, or the iliac vein. So you in a limb, lower limb, or the upper limb, you get the axillary vein. So axillary vein thrombus is very rare, but lower limb thrombus are very common nowadays. So a patient with the cellulitis has to be differentiated from a deep vein thrombosis, DVT. So for that purpose, definitely, if you have doubt, if you have got a strong doubt, because that is a life-threatening problem, and the treatment of that patient is totally different from a simple cellulitis treatment, naturally, that has to be identified. So that needs to have a Doppler or duplex examination of that area. That is another investigation. Actually, cellulitis is not being diagnosed by Doppler. Doppler is to exclude DVT in a patient with the cellulitis. That's the importance of investigation there. And when your management, all this edematous limb, you have to have a limb elevation. Is very effective in all these patients because dependent drainage of the lymphatic, opening up of the lymphatics, and the extravasated fluid, the edematous fluid has to be drained back into the systemic circulation. Limb elevation is one of the effective marks, and appropriate antibiotic depending upon the and because here in a cellulitis you may not be getting enough fluid for a culture and sensitivity. If it is available, that can also be done, and appropriate antibiotics may be selected by the culture. If not possible, the bacteria you expect, like a Staphylococcus, the bacteria against such organism is the one that is being usually preferred. Maybe a cephalosporin or a penicillin or erythromycin can be used. And definitely how to control the diabetes. And the local wound care may involve simple dressing, or if there's a blood that has to be removed. If there's a dead tissue, a debridement, debrima of the dead area, that's called a debridement. And if the facial compartment tension is very high, with a cellulitis there, you have to release the tension in the facial compartment of the limb to avoid ischemic necrosis of the area or the muscle or the limb itself. So a fasciotomy is a proper procedure that it may have to be done. Then if the patient goes in surge and modes, definitely supportive care with IV fluids, renal, respiratory, and cardiac support. Dialysis, urinary output has to be maintained. All these patients, a catheter is put, an intake output chart is maintained, and adequate urine output, at least 30 ml per minute of urine has to be there in all patients with for an adequate perfusion there. The respiratory rate is monitored. If the respiratory problem happens or respiratory dysfunction, respiratory failure happens, you have to give oxygen, you have to give, so you might have seen the PEEP, support, the ventilator support to the patient with a positive end pressure or pressure PEEP support. And in a patient with cardiac with the drugs like dobutamine, dopamine, noradrenaline, all these cardiac supporting drugs also has to be done. So proper antibiotics, IV antibiotics is needed in the severe patients, or oral antibiotics, and supportive care. These are the way you will treat the cellulitis. Another surgical conditions where you may get in is erysipelas. Erysipelas is the word meaning term is a red streaking skin. Red streaking skin. The features I have shown in the inflammation are actually an erysipelas patient, where there's a red streak. You can see a red streak there. Red streaks are there. And it's actually an inflammation, acute spreading inflammation of the outer layers. So cellulitis is the skin and subcutaneous fascia. Here, only the superficial layer, the epidermis and the superficial part of the dermis. The reticular dermis and papillary dermis might have been only the one that is involved in these conditions, and the lymphatics. And here, the organism most often or exclusively by beta hemolytic streptococci. Beta hemolytic streptococci. And there is a very well demarcated skin rash, whereas the other one, because the subcutaneous tissue is also being involved, the demarcation is ill-defined in a cellulitis, more superficial than cellulitis. Leg, hand, face are the one. And previously, it was very erysipelas is once when you go to the literature, when you go to the textbook, erysipelas is most often being described in the face. But nowadays, erysipelas is much more common in the leg and hand area. In the past, when it happens in the face, it is being differentiated from a cellulitis of the face or the parotid abscess by the Millian sign. Millian sign is the spreading of this infection into the ear, because your fascia, the facial attachment into the cartilage, external auditory cartilage happens in the preauricular area. So a deeper space infection never goes to the skin of the ear. Whereas erysipelas, it will go and spread. So that sign is called Milan sign. Milan sign is positive in an erysipelas. And treatment is again penicillin, erythromycin, roxithromycin, or clindamycin. Most of them it can be treated. But the redness and edema may persist for a longer time. But the evidence of infection, the inflammatory process will subside in the early phase itself with the antibiotics. One is a lymphangitis. Lymphangitis is the suppression or non-suppurative infection of the lymphatics of skin and subcutaneous area. Again, due to beta hemolytic streptococci. But here, staphylococci and Clostridium organism can also be incorporated. You can see red streaks, painful streaks of affected lymph. It's a lymphatic obstruction. And there will be associated lymphadenitis will be there. In our part of the country, or our part, the Alapi, filarial lymphangitis is one more common. So the presence of filarial microlarvae is itself creating inflammation, infection in the lymphatics. That is the one commonly involved. But once there is a recurrent infection with edema, so the presence of edema itself is an etiological factor for developing lymphangitis. So any sort of lymphedema, may say after axillary resection in a patient with carcinoma breast or a patient with a congenital lymphedema, there are also prone to develop lymphangitis. So lymphangitis may be due to filarial larva in the initial insult, but later the inflammation might have been due to the presence of chronic lymphedema. The treatment is limb elevation, antibiotics, and definitely the edema has to be such of it is acute in onset. But if it becomes a chronic one, resolution of the edema may have been a difficult problem. Only thing you can offer to the patient is to prevent further development of edema by blocking further lymphatics by recurrent lymphangitis. So avoiding the occurrence of lymphangitis or early treatment of lymphangitis is the most important point regarding the blocking or the prevention of the development of a chronic lymphedema or filariasis. So some patients may, with frequent episodes of infection, may have to be given prophylactic antibiotics like a benzathine penicillin or penidural in a long-term way to prevent the recurrent infections. Then, so next development is a pyogenic abscess. It's a localized collection of pus in a cavity lined by granulous tissue, and it containing pus. Actually, pus is bacteria, the WBC, the toxins of the bacteria, and the dead tissue. The dead tissue is formed by the liquefaction and destruction of the area by the lysosomal enzymes created by the presence of bacteria. The infection might have been entered into the system either by a direct injury, like a external injury by laceration, aberration of a cellulitis that turning to abscess formation, or it can be arising from somewhere, having a lung abscess, and from the lung abscess, embolic abscess content goes into some other area and abscess formation into the brain or into the skin area there, or it can be to the lymphatics, like a filarial lymphangitis, inguinal adenitis, and inguinal abscess formation. Organisms most often been encountered are the staphylococci, streptococcus, E. coli, Klebsiella, Pseudomonas. So gram-positive, gram-negative, and anaerobic bacteria, all these organisms. The other one, usually you get erysipelas is only a gram-positive organism. Cellulitis, you can have gram-positive and gram-negative. Whereas in a pyogenic abscess, you can have gram-positive staphylococcus, streptococcus, gram-negative E. coli, Klebsiella, Pseudomonas, or anaerobic, that is non-oxygen dependent bacteria like Bacteroid, also maybe they are in the pyogenic abscess. Clinical features are fever, chills, rigor, and throbbing pain. There will be fever, chills, rigor, and throbbing pain. And you get a localized swelling with evidence of acute inflammation, like rubor, calor, dolor, pallor, and functional area. There will be fluctuating swelling. When you're palpating that area, there will be fluctuating swelling, swelling with evidence of collection, fluid. So a fluctuating swelling will be there. The abscess might have been an external one, as you see here in the face or the limb, or it can be internal, like intra-abdominal, intrathoracic, intracranial. And investigations you may encounter is the leukocytosis, as in the cellulitis. An ultrasound may localize the swelling, and evidence of fluid collection may be identified, especially the deeper areas. Where in doubt, a contrast enhanced CT scan may be helpful, especially in a patients with a deep-seated abscess, like liver abscess, renal abscess, the subdiaphragmatic abscess, pelvic abscess, etc., or intrathoracic or intracranial abscess. Complications of this abscess are, this abscess may produce local destruction of the tissue. It may extend, if it is not being treated in the proper way, it extends to the surrounding area. It produces bacteremia, ulcers, and modes if it's not been treated. It may produce embolization of the thrombus, embolization of the abscess content into different areas, and pyogenic abscess in some other area distal to the original abscess. And it can call metastatic abscess if it is not being properly treated by draining, because all the abscess need to be drained in a proper way. If not being done, but you have given antibiotics to localize it, because the spread of the infection will be prevented by giving a large dose of antibiotics. But the abscess still it is there, so it needs to be drained or naturally being absorbed in a longer period. So that means it forms a solid area called antibioma. Antibioma is a swelling, sequelae of the abscess with a walled off wall and without evidence of any acute inflammation. Then site-specific complications of the abscess might have been, if it happens in the head and neck region with the pressure onto the windpipe, it may produce a stridor. In an intracranial tension, in intracranial abscess, it may produce a raised intracranial tension with a papilledema, headache, vomiting. It may produce dyspnea or bronchofistula in an intrathoracic abscess. In a pancreatic abscess, it may erode into the blood vessels. Intravenous vessels may producing a larger dose of bleed because the surrounding blood vessel may get eroded. The mesenteric vessels may get eroded and a bleeding. A torrential, potentially dangerous bleeding may happen into the intraperitoneal cavity or into the duodenum with a hematemesis can happen. DD, all the abscess needs to be differentiated from aneurysm, especially in a site where the blood vessels are there, like a femoral abscess has to be differentiated from a femoral hernia, an axillary abscess or a neck abscess has to be differentiated. Axillary aneurysm and internal jugular aneurysm. And another one is a rapidly spreading soft tissue sarcoma, like an Ewing sarcoma or a high-grade sarcoma may mimic an abscess. A hematoma or a cold abscess is another differential diagnosis. Cold abscess is the abscess sequelae of a tuberculosis. Why it is called cold? It lacks the features of inflammation that I already evaluated. The 5 pillars of acute inflammations are lacking in a pus collecting pathology by tuberculosis. That's called cold abscess. Management of abscess, all abscess needs to be aspirated, all need to be drained properly, needs to be drained. So draining maybe done by fluid aspiration like this. You can see the syringe aspiration of an abscess of the hand, or in a deeper planal, you can do a guided with an ultrasound guide or CT guided aspiration. Or if not done, or if not possible or not being successful by a aspiration, this pus has to be drained by an incision drainage. Mind you, all this incision drainage open in a periphery. Usually you won't close the wound. You will always keep it open and allow the pus to drain further because there will be some little of reaccumulation of the pus can happen. So if you reclose, the abscess reaccumulate. So all the peripheral abscess drainage has to be kept as open one. And a deeper abscess has to be drained with a drainage tool. And while doing an incision and drainage, a rule has to be followed called Hilton's rule, where if you are doing an abscess drainage in an area near to a neurovascular bundle, your incision always has to be parallel to the neurovascular bundle. So example is when you're having an abscess in the inguinal region. Usually the incisions in an area, in a surgeon's primary principle in doing an incision in any other purpose other than the abscess drainage, you go through the skin creases. So the inguinal crease is horizontal. But when you put a horizontal incision, there is a very high chance of you may injuring the femoral artery, femoral vein, and femoral nerve. To avoiding such problem, this exception is there in a drainage of the abscess. When you are draining the abscess, always go parallel. So there the cosmosis is not at all a problem. You are not considering the cosmosis. The skin crease incision is put to help you get a good scar in the postoperative period. So that is not being considered regarding the problem of a complication of an injury of the vessel if happens in a horizontal incision. So all the incisions you have put in an incisional and drainage area has to be parallel to the blood vessels. That's called the Hilton's rule. You have to have culture and sensitivity of the pus that you are obtaining and give the proper antibiotic. Another florid problem that may happen after your cellulitis or other things, or primarily because of the deficient immunity of the patient or the florid virulent organism entering into the body, you may get a necrotizing fasciitis, where there is a necrosis of the skin, subcutaneous fascia, even the muscle happen in a rapid fashion. And most often the organism involved are the anaerobic organisms like bacteroid, anaerobic streptococci, peptostreptococci like one. And there's a different types of organ. Anterior abdominal wall is called Melnius gangrene. On the scrotum is called a Fournier's gangrene. It's a rapidly spreading, and SIRS and MODS will happen in the early phase. So broad spectrum antibiotics and circulatory support has to be given in all patients, and a wider excision with the debridement. That's the one that has to be. So you should not wait for the tissue to settle down. you have to be proactive. You have to give adequate fluid and adequate antibiotics and take the patient to the theater with anesthesia. Remove all the dead tissue immediately, unless the patient, you may lose the patient. That's a necrotizing fasciitis. This is a surgical site infection. Already I have mentioned. ഹലോ, എല്ലാവരും ഉറക്കമായോ? എങ്ങനെയുണ്ട്? എങ്ങനെയുണ്ട്? ഇപ്പൊ ഞാൻ പറഞ്ഞത് നിങ്ങൾ ടെക്സ്റ്റ് ബുക്കിനകത്തൂടെ വായിക്കണം. മനസ്സിലായില്ലേ? ഇതില് വളരെ വൈഡായിട്ട് പല സ്ഥലങ്ങളിൽ നിന്നുള്ള കാര്യങ്ങളാണ് ഞാൻ പറഞ്ഞത്. കുറച്ച് ഫിലോസഫിക്കലാണ്. ഇനിഷ്യൽ ഹിസ്റ്ററി ആയിട്ടൊക്കെ പറഞ്ഞ കാര്യങ്ങളൊക്കെ തന്നെ സാധാരണ ടെക്സ്റ്റ് ബുക്കിൽ നിങ്ങളുടെ ഉള്ളതല്ല. ബിക്കോസ് മൈ ഇന്റൻഷൻ ഈസ് ടു മേക്ക് യു ടു ഗെറ്റ് എ ഇൻവോൾവ്മെന്റ് ഇൻ ദ ഹിസ്റ്ററി ആൾസോ. ഹൗ ഡസ്, നമ്മളിപ്പോ എന്താണ് ഈ മോഡേൺ മെഡിസിൻ എന്ന് പറയപ്പെടുന്ന നമ്മുടെ ഈ ഫീൽഡിൽ നമ്മൾ എങ്ങനെ ഇപ്പോൾ എത്തപ്പെട്ടിരിക്കുന്നു. ഇപ്പൊ ഈ പാൻഡമിക്കിന്റെ സമയത്ത്, ഇപ്പൊ ഈ പറയുന്ന കോവിഡ് പാൻഡമിക്കിന്റെ സമയത്ത് ഈ സയന്റിഫിക് മെഡിസിൻ, മോഡേൺ മെഡിസിൻ ആൻഡ് സയന്റിഫിക് തിങ്കിങ് ഈസ് വെരി വെരി ഇമ്പോർട്ടൻറ്റ്, വെരി വെരി ഇമ്പോർട്ടൻറ്റ്, ബിക്കോസ് ദിസ് ഇസ് ആപ്റ്റ് ടൈം ടു ടോക്ക് അബൌട്ട് ദ സയന്റിഫിക് വേസ്. സോ സയന്റിഫിക് വേസിൽ എങ്ങനെ നമ്മൾ ഇവിടെ എത്തപ്പെട്ടു, ഇന്നത്തെ നിലയിൽ നമ്മൾ ഇന്ന് ഈ 24/5/2021 എത്തപ്പെട്ടത് എങ്ങനെയാണ്? മൈൻഡ് യു, ഇന്ന് നമ്മൾ ഈ കോവിഡിനെ കുറിച്ച് പറയുന്ന പല കാര്യങ്ങളും 2025 ചിലപ്പോൾ സത്യമാകണമെന്നില്ല. അന്ന് കിട്ടുന്ന നമ്മുടെ ഇൻഫർമേഷൻസ്, നമുക്ക് കിട്ടുന്ന ഫർദർ ഇൻഫർമേഷൻസ് വെച്ചിട്ട് യു മേ സേ ദാറ്റ് വാട്ട് ഓൾ യു ആർ ടോട്ട്, പ്രാക്ടീസ്ഡ്, preached will be wrong. So once you believe that it is a wrong one, you have to accept it. That's why the importance of the Galen. Galen പറഞ്ഞത് ലോഡബിൾ പൾസ് ഉണ്ടാക്കുന്നതാണ് ഇൻഫെക്ഷൻ ആണ്. Just like people are applying cow dung on your body, creating, preventing or protecting the immunity. But that was there in older days also. But in the modern medicine, people realize that that is wrong. You have to be scientific. So that's why, and the olden days scientific acumen development is still important in our newer modern era also, so-called modern era. So that's why I go through the history also there. Infection part is in fact very very important. The surgical site infections, the cellulitis, the syphilis and other things. Hope you have got some idea about the infection rate. Okay, thank you.
Thank you, sir.
ഷാജിത്തെ ക്ലാസ് കഴിഞ്ഞ പിന്നെ എന്തായാലും ചെയ്യേണ്ടത് മറ്റേ ഇതിന്റെ കാര്യം